All right, well, welcome to this pharmacology drug class review in the large category of anti-diabetic drugs with a specific focus on Amylin Analogs. Now, this drug class is part of many other drug classes in the large category of anti-diabetic medications that give us as clinicians potential options for patients seeking tailored, tighter control of their diabetes. However, we will see that out of all the anti-diabetic drug classes available, this one in particular has a very focused use in patients with diabetes. Now with that, I'm Dr. Busti, and thank you for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind the pharmacology and the drugs that we use every day. When we understand the why, the how becomes easier, and that's where the mechanism starts to predict the desired and expected therapeutic effects, even side effects, monitoring parameters, and counseling points, which is very relevant in this case. Now, as with all of my drug class reviews, we cover core content, agents, what's indications, the net sort of benefit, why would I grab this drug and use it in the overall management of a patient. And then we start to dive a little bit in that more in depth of the pharmacology, pharmacodynamic, kinetic considerations, which are relevant in this case, and then bridge over into that clinical application, the pearls of application in everyday real-world clinical practice that I wish people would have told me when I was learning these things. All right, with that, let's jump into the agents. Thankfully, it's easy. We got one, right? That's nice. But you still have to memorize many times the drug in a drug class. And if you look at formularies in a hospital and preferred drug lists and all these things, typically every drug class has to have at least one agent. Now, you see that with one agent also, it can also indicate that maybe this drug class really doesn't offer that much bang for the buck, right? And so if there was money to be made, you would think that more pharmaceutical companies would make options that fit into this. Well, they don't maybe necessarily fit into Amylin analogs, but they fit into other mechanisms that align with it. And those are other drug classes, like GLPs and other stuff like that. All right, so Pramlintide is the only agent here, and that's what you need to know. All right, moving on to now we're going to focus on our indications and uses. And this one may stump you a little bit. It says type 1 and type 2 diabetes. Okay, as an adjunct to, most commonly, prandial insulin use. That's a very specific use of wording there at the end, okay, because you're going to see here the net benefit is what matters. So let's talk about the net benefit of this drug class. Why would I add it on? Okay, who is that patient seeking that focused, tailored response? All right, so that is the patient who seeks postprandial glucose control, okay, while promoting a small degree of weight loss. Now, in type 1 diabetics, think about that. Most patients with type 1 diabetes do not typically have weight problems. They're usually thinner, okay? Not always, but they're usually, okay? They also lack insulin resistance. They're much more sensitive. I'm saying they have none, but they have more insulin sensitivity than a patient with type 2 diabetes, where there's insulin resistance, and we use very different doses, okay, for those reasons. And the reason that matters is because we don't want a patient with type 1 diabetes who's already thin to lose more weight. That is not our goal here. So you have to find that right patient, right scenario. Their postprandial glucoses are still a little too high, and they want good, tight, tailored control where they're going to get about another 0.7 maybe reduction in that A1C. So that is a very focused niche of a patient population who want that. That's why I use that terminology. Tight, tailored treatment. Okay, so let's now jump into some of the pharmacology. What is this drug doing that would cause a weight loss and that kind of reduction? All right, especially in the postprandial. So it's doing something in that case in the context of a meal. I mean, you just put 2 and 2 together. It's not rocket science. So we must be modulating the functional activity of the GI tract, and we are. Right? We also do some other endocrine effects. So amylin analog is secreted along with insulin from the pancreatic beta cells. Now, it does this. It delays gastric emptying. So let's just stop right there for a second. If I have a drug that delays gastric emptying, then what underlying comorbidity or existing problem would then potentially be worsened in that scenario? Yeah, gastroparesis. So if I already have a problem with gastric emptying and I now give a drug that causes delayed gastric emptying, then things are going to sit in the stomach longer, stretch the stomach wall, and usually facilitate satiety where people feel full sooner, quicker. So they can't eat the same volume. So they may even decrease their caloric intake, which then decreases the glucose changes in that meal. So remember, this is an adjunct to people already on typically prandial insulin. That means they're taking insulin at the time of their meals, depending on how fast or rapid acting it is. And the reason that matters is because if you decrease the caloric intake, but you have expected a certain amount of glucose to be present, and you're taking a certain amount of insulin, you might create the perfect storm for delayed glucose levels and lower glucose levels, and you will now cause the patient to become hypoglycemic. And that's why, the mechanism correlates to what comorbidities that you avoid. Why would the patient be at potentially higher risk, if used wrong and timing is off, of hypoglycemia? So you really need an educated patient who really wants that tailored, focused, tight control of their diabetes for this, because they need to understand what they're doing and why they're doing it, and then how they may need to modulate their dosing of their other insulin around the meal. Okay? So we have delays gastric emptying, we decrease postprandial glucagon. Okay, so remember, glucagon would normally be released when we start to get low, and it's going to help raise the plasma glucose levels. So it could delay that. It reduces appetite through a centrally mediated mechanism. So our desire to eat is going to be changed as a result of that. Okay, so there's kind of three main prongs to the mechanism that then makes sense of comorbidities, side effects, and the potential of those side effects if used wrong. It also helps point us to counseling points, doesn't it? So guys, this is a great example of understanding why, when you learn the why, it translates over into the how. How do you manage the patient? How do you counsel them? Okay? Now, from the pharmacodynamics considerations of pramlintide, it's important to consider that in the context of when do you give it in relation to the meal, and also when is it going to peak and how long does it stick around, because that delay in the glucose is what's going to be, you're changing the curve, right? Now, if you were to measure it glucose levels continuously, and if you have a continuous glucose monitor, that helps. And many patients with type 1 do, and many type 2s now are doing that more. So you see here that the peak is about 20 minutes and the duration is 3 hours, okay? And it's administered immediately before the meal. Well, so is the insulin sometimes. Again, depending on how rapid acting in that time in relation to when you think that peak is supposed to be there. So if you already have an established insulin regimen that works for your diet and your lifestyle, and then now you start this, and you don't compensate by potentially reducing the dose of the insulin or by making sure you check the levels, you could find this patient having insulin present and no glucose there, or the expected glucose there. And so whatever glucose is present is now going to be even lower. And that's why patients can experience hypoglycemia. All right, now we're going to move into the clinical knowledge application piece, okay? And this is where we talk about place in therapy, but then also add on and reinforce some of these clinical pearls. So I have a series of tables, just like with other topics on the anti-diabetic agents. So I don't mean to be repetitive at some level, but depending on when you come into these lectures, these tables are all available for you at thisiswhy.health. That URL is present not only on the image, but at the link to this set of files and images is available in the description of the video or the podcast if you're on the podcast channels. Okay, you can get them for free at thisiswhy.health. They're there for you. Feel free to use them however you want. Okay. Now, this table is a general treatment strategy. It breaks down type 1 versus type 2. And remember, Pramlintide is a non-insulin based treatment that can be used for either one of them. And it's listed here. Now, this is meant to be high-level overview, not details, comprehensive, every potential treatment option. Don't look at it like that, okay? But you see here we have medical, nutrition therapy, physical exercise. That's in both. I'm not going to stop saying that because I think everybody wants a pill, shot, something now to solve their problems. They don't want to get to the root of the problem. They don't want to manage their conditions correctly all the time because we fail to reinforce those points. But this is huge. And of course, continuous glucose monitoring is preferred, CGM, is preferred in this patient population for sure. It's being used more commonly in patients with type 2 diabetes as well, okay? But obviously up here with type 1, insulin is the mainstay of treatment. And there's different ways and strategies. I'm not going to dive into that. But you see here plus or minus Pramlintide. And there's your Amylin analog right there. And it's plus or minus because remember, it's not for everybody. It is for that patient who wants tailored, very strict, tight control, and maybe they need to lose a couple pounds, but not very much weight. Okay. So you have to then say, okay, well, what comorbidities do they have? Make sure I don't cause that. Or their diabetes may have caused gastroparesis because of that nerve damage. So patients with diabetes do suffer from diabetic gastroparesis. So if that's the case, this may not be good for that patient because you're going to worsen that condition. When you look at type 2 diabetes, you see that we have monotherapy after diet, exercise, right? Monotherapy or in combination with a non-insulin based regimen. Well, this is a non-insulin based treatment option. And then of course, as you go down, you start to see the addition of insulin treating other comorbidities like thyroid disease and stuff like that that would affect our metabolic demands. Now, moving on to the drugs that we would use to treat patients with type 2 diabetes in particular we break those down in because you have to have a functioning pancreas, the secretagogues, right? And I'm not going to cover them here. I'm just pointing that out. This is another table. Summarizes the secretagogues. So you have meglitinides, sulfonylureas. And then we have the non-secretagogue agents that are non-insulin based. Alpha-glucosidase inhibitors, the big one DPP-4 inhibitors, GLP-1 agonist, right? TZDs, SGLT2 inhibitors. All of those options are potentially available. And then we sort of get into this other chart here or table that summarizes comorbidities on the left, conditions that patients might have. What drugs might you consider trying to use? Again, not perfect, not meant to be overall comprehensive for every patient scenario. It's a generalization guide, okay? And then over on the far right column is, these are the drug classes you probably should use with either caution or avoid altogether if the patient has this comorbidity. Now there's a lot of comorbidities up here, but the one that I want to point out to you is, and as a reminder why this table was put together in part, is gastroparesis, okay? Now gastroparesis is, you see that we don't really have a drug that we should try to use in those patients. A lot of these drugs do affect the GI tract, alpha-glucosidase inhibitors that would, exacerbate it potentially. Metformin, of course, GLP-1 receptor agonist. So patients with the GLP-1 receptor agonist or Pramlintide, those would be the two main classes that you should think of first, right away, that you probably want to avoid. in this patient population with the comorbidity of gastroparesis. If they had inflammatory bowel disorder, IBS, partial obstruction, I probably would also give some pause, but it's not sort of the absolute. Gastroparesis is probably the higher yield type of content specifically for things like board exams. But again, clinically relevant. All right, moving on to the dosage considerations, administration issues. This is where the clinical pearl about insulin dose, especially if you're on an established regimen that works for you based on the lifestyle diet before Pramlintide, and then you start Pramlintide knowing that you're going to delay glucose movement into the body and that postprandial glucose expected level, that you need to reduce the dose of that insulin, okay, by 50% when you initiate, okay, to avoid. So you'd rather err on the side of precaution and maybe even have their blood sugars a little bit high than for them to plummet, especially if the patient has type 1 diabetes, where they're very sensitive, right? Remember, they have less likely to have insulin sensitivity problems, okay? Now, it is administered subcutaneously, typically in the abdomen or thigh right before the meal. We typically recommend avoid using the arms because we use our arms more. And as you contract muscles, you're going to change the absorption and the blood flow to that muscle. Not everybody uses their abdominal muscles like they should, okay? So it tends to be more consistent in the pharmacokinetic absorption of that, right? The injections should be at room temperature to kind of decrease that injection site irritation. And then lastly, as part of the administration that's important, do not mix this with other insulins. We have a lot of drugs that have some nuances with that, and this is one of them, okay? Now, again, contraindications, warning considerations. We've already talked about gastroparesis. I've already said that a couple times because you're having that delayed gastric emptying, and you will just make them worse. So what would be the manifestation? What would be the problem? Well, when they eat, they're going to throw up, most likely. They're going to get very nauseous, and they're going to eat less, which may cause them to lose weight. They may also have more risk of postprandial or prandial hypoglycemia because of that lower amounts of glucose being brought in because they're not feeling good, plus then the drug is present, and then they have insulin, and whammy. You've created the perfect milieu. So hypoglycemic unawareness is a huge problem when patients don't understand this, and if they get confused or altered, then they're in trouble, okay? Now, severe hypoglycemia, okay, these are patients that are going to be more severe within that and they're higher risk, 3 hours. Think about the duration, the pharmacokinetic profile of Pramlintide in its dosing, okay? Now remember, the type 1 patient with diabetes is going to be at higher risk of this because they're very sensitive to insulin compared to patients with type 2 diabetes. And so just be very cognizant of that. Now, if patients are not on insulin or secretagogue-based therapies, then it's probably not as big of a risk, right? So anything that is causing insulin to be secreted like a secretagogue or insulin is being administered would put the patient at risk when you're using Pramlintide. I've never seen personally Pramlintide used as monotherapy. I'm saying you couldn't do that. I've just never seen that done, okay? That's probably not the preferred or best way to manage patients. Now, bariatric surgery speaks for itself. You do gastric bypass surgery, well, you're going to cause shifts in the way the bowel empties itself and moves, and the ability for those nutrients to be absorbed at the right time. And so you just need to be cognizant about that and when you should start that in the context of the patient's recovery and their dietary practices. Now, what about drugs that can decrease gastric motility? Any drug with anticholinergic properties is likely to decrease the motility of the gastrointestinal tract and cause constipation. So if I have a drug like Pramlintide and drugs like with anticholinergic properties like Benadryl, there's a lot of drugs with anticholinergic properties. So you have to keep that in mind, that the two of those can create additive or synergistic effects. We already talked a little bit about injection site reactions, especially when you try to administer the medication, do it at room temperature. Patients can develop some injection site reactions, most commonly erythema, that usually resolves after several days or weeks. So our main sort of monitoring parameters, which turn into counseling points, is the GI side effects, nausea, vomiting, constipation, the monitoring the risk of the prandial, postprandial changes in the glucose, having to adjust the insulin dose, again, by 50% first, error, and then try to get them back under control. Again, this is going to require an educated patient who's very motivated for that very good, tight control. And then from there, once you get them stabilized, you just monitor that A1C every 3 to 6 months as you normally would, and make sure that they know how to treat the hypoglycemia. So remember, the hypoglycemia is commonly the rule of 15s. You administer 15 grams of sugar, wait 15 minutes, and you should see a change, and make sure that glucose level goes up in that time frame. And so just be cognizant of that. We want to keep their blood sugars preferably above 70 milligrams per deciliter to avoid problems. Okay, guys, so that makes up the Amylin Analogs, okay, or mimetic agents known as Pramlintide. There's only one. Remember, it can be used for type 1 and or type 2 diabetes, most commonly as an adjunct to prandial insulin use. Remember, it's going to work on delaying gastric emptying. It's also going to affect the prandial glucagon secretions, and then it's also going to influence our desire to eat and our appetite by affecting it centrally. Now, that can lead to nausea, weight loss, hypoglycemia if used wrong, and of course the injection site reactions, okay? Now, so just be cautious of avoiding using these drugs in patients with GI disorders, specifically gastroparesis. So those are the take-home points, main clinical pearls. I hope you found that to be helpful. Put in the large context of options and how we manage these patients. Please follow us and subscribe on YouTube. We really appreciate that. Again, please take the moment to give us a like. We really value and need that. It helps to support the channel and doing things for you guys. Again, join us at thisiswhy.health. Let us know how we can help you, serve you. We learn from each other, guys. I value input and feedback. I learn from you guys just as much as hopefully you learn something from me. So I'm Dr. Busti. Again, thank you for joining me. Thank you for investing in your knowledge and really seeking to understand why you do what you do or what we do every day in clinical practice, because that makes how we manage patients easier and they benefit from that. So thank you and take care. We'll see you next time.